Respected chairpersons, respected discussants, moderators, and dear audience, I am very much delighted to be here in this gathering, especially the radialist and those who are interested in radial angiogram. And I am feeling proud to be here as myself try to do 99% of my case in radial route. So my topic is spasm, loop and knot, an exciting journey of radial intervention. As all of you, those who you are doing radial procedure, through radial procedure, day to day you have to face this type of problem. Just I will show a few cases regarding this. My case on Mr. J, 47-year-old male. He was diagnosed as non-STMI. He had diabetes. He is a smoker, and his ECG shows STT changes in lead 2-3 AVF, and echocardiography, no regional motion abnormality, good LV systolic function, and we did angiogram through right radial route. Let us see the angio. In this view, we see there is 100% occlusion in the LCX in its mid part. Left main normal. LAD type 3 vessel normal. LCX has 100% occluded in its mid part. While doing this angio, just we look at the pressure curve, suddenly pressure showing nothing, pressure 0. Yes, we have Professor Abu Azam sir with us. Welcome, sir. Would you please come to the dais, sir? Thank you, sir. We are very much delighted as you are here. So when at this stage we suddenly saw that pressure is not showing. So what happened? We just looked at, you see the picture, the tiger catheter full of air and there is knotting. So we just tried to do unknotting the catheter and try to push and pull the catheter, try to unknot the catheter by rotating or moving in opposite direction, but it doesn't work. Then we try to push the knot part of the catheter to the spacious area and push the upwards, and that works. In the spacious area, the knot become unknotted. So after this, we just check the radial artery. If there is any dissection or any other complication not, it's okay. Then we took another tiger catheter and do the right side, right coronary normal. Then we did PCI to LCX. Stenting done in LCX. So this is the final result. So this is my, after that we just, before coming out, we just check the radial artery. It's okay. So this is my first case. My second case is just a couple of days ago, this patient admitted in our unit. We just, she was a patient of WPW syndrome, but at this time she presented with chest pain and troponin was little bit raised and she was diagnosed as non-STMI. As WPW syndrome, ECG, previous ECG was SBT, but at this time it was sinus. And as the patient's troponin was raised, we tried to see the coronary angiogram. Let us see the coronary angiogram. We did coronary angiogram through the right radial route. So you see this picture after cannulation, after placing the wire, then when we try to advance the catheter, catheter is not advancing. Catheter is stuck. There is obstruction. Catheter is not moving. So we withdraw the catheter wire, then we put the dye through the vascular access sheath, and we saw that picture. There is a huge spasm in the brachial artery, brachial and above artery. Then we took a balloon-assisted technique, BAT. Then we took a PTCA guide wire and a balloon, and by balloon-assisted technique, we further movement and able to cross the spasm of the brachial artery. So after reaching the arch of the aorta or subclavian artery, we draw the balloon and the guide wire catheter. Then we put regular wire and did the coronary angiogram. Actually, the patient's coronary angiogram reveals normal findings, as she was a WPW syndrome. So what is balloon-assisted technique? Before coming back, we saw again there is a spasm. We have given antispasmodic like verapamil, GTN. Still there is spasm, but pulse is regular and good volume of pulse. So we finish the angiogram. So what is balloon-assisted technique? When there is a spasm, severe spasm, we have to take this technique. Balloon-assisted tracking to overcome a spasm or tortuosity. We need a compliant angioplasty balloon, 0.014 standard angioplasty wire, and balloon for 6 French catheter, 2 millimeter balloon is compatible. For 7 French catheter, 2.5 millimeter balloon. For 8 French catheter, 3 millimeter balloon. And we have to make sure that when we will advance the balloon with catheter, the 2/3 of the balloon should be out of the catheter, and inflate the balloon just above the nominal inflation pressure. Just balloon should be inflated. So look at this. The 2/3 of the balloon is outside the catheter, and balloon is inflated. So why it is needed? How it works? The conical shape of an inflated balloon tip increases the flexibility. It eliminates the obstruction of the edge of the guide by atheromatous plaque or tortuous vessels. It minimizes the Reza effect. You look, if we inflate the balloon just in front of the catheter, the Reza effect of the catheter edge will be minimized, and with the conical shape of the balloon, it will overcome the spasm or tortuosity. So this is about my case. My third case is Mr. E.H., 45-year-old male. He has respect to diabetes, hypertension. He presented with us inferior MI and ECG showing inferior hypokinesia. We did coronary angiogram through right radial route. You see the loop is there. So we first have to cannulate. We had difficulties to cannulate the left system due to this loop. And we did angiogram right coronary. There is a distally 100% occluded RCA. And it was we faced difficulties to cannulate the coronary artery, left system, as you see. What types of loop here? So anyway, we did the coronary angiogram, and during PCI, we pre-planned that we will bring the patient another day, and we will go for femoral route and did the RCA lesion stenting. So this is my last case, fourth case. A 65-year-old female, old MI anterior. She had diabetes, hypertension. She had old anterior MI. Echo shows anteroseptal hypokinesia, LVF 40%. We did coronary angiogram through right radial route. Look at this road. This is a very beautiful road. anybody will be happy to walk through this road to reach our director, sir, Professor Minhaj Uddin sir is with us. We are very happy to see him. Sir, please, would you please come to the dais, sir, along with Abu Azam, sir. Sir, please come, sir. Actually, all of you know, with the guidance of our Professor Mir Jamaluddin sir, who made this radial intervention popular in Bangladesh, and all of we are doing in the guidance of Professor Mir Jamal sir, a radial intervention. So, as I am talking through this road, if anybody can walk, he will be happy to reach the goal or to reach anybody's heart. This road, okay, this road might be acceptable, no problem. Also can go through this road. But what about this road? This is a hilly road, zigzag road. So there will be difficulties to reach this road, to travel this road to reach destination. Slide আসতেছে না তো? Okay. So it is very difficult to travel this hilly zigzag road to reach the destination. So now come back to my case. 65-year-old female, she had anterior MI, LV ejection fraction less. So we did coronary angiogram through this, through radial pathway. You see the axillary artery and subclavian artery, so tortuous. You look, you see the loop is there, probably there may be arterial luceria is there. So there is a loop create another heart shape above the heart of that lady. So anyway, we did the coronary angiogram. And patient had TVD. We send the, as the patient had TVD, we just we did the lima. While doing the lima, the story not finished yet. While doing the, trying to engage lima, we saw that pressure is again not showing. So let us see what happened there. There is some knotting. So we unknot that rotating the catheter in opposite direction, and this time we did it successfully. And finally, we, after doing angiogram and lima, we took out all the assembly and completed the angiogram. So, Mr. Chairperson, I am just about ending my presentation. What are the learning points from these cases? While doing coronary angiogram, if pressure is not being shown, look for catheter kinking or not. For unknotting the catheter knot, opposite torquing is needed, especially in the larger vessels. Radial and brachial artery angiography could be done when there is suspicion of spasm. Once upon a time, there was a tradition that after cannulation, we just see the radial artery angiogram. Not likely every case. If any obstruction is there, any obstruction is there for advancement of catheter wire, then we could see the radial angiography or brachial angiography. When there is a spasm, PTCA guide wire or balloon assisted tracking is needed for catheter advancement, as I have shown you in my third cases. So this is my team. Thank you very much.